All right, great. So per request, we're going to be focusing on the psychopharmacology of atypical antipsychotics today. I have no disclosures, and basically what we're going to be doing, I figured we would do just a really quick review on symptoms of schizophrenia, the 4 dopamine pathways in the brain which correlate to some of the effects and side effects we see with our antipsychotics, evaluate some of the properties with the atypical antipsychotics, and then discuss some of the side effects, how to switch or taper off, and then some kind of clinical pearls with some of the medications. So first I would thought, basically we're going to be focusing on FDA-approved indications today. We use a lot of these medications off-label, but today we'll focus on the FDA-approved. So as you can see, all of our atypical antipsychotics are approved for schizophrenia. They really, in all the guidelines, primarily are considered first line for the treatment of schizophrenia. Then some of them do have monotherapy or adjunctive indications to lithium and valproic acid for bipolar disorder, as well as mania and depressive episodes monotherapy. And then we have a few indications for adjunctive therapy with antidepressants for major depressive disorder. Really what I wanted to point out here is clozapine actually is the only antipsychotic that's approved for treatment-resistant schizophrenia. It actually has shown superior data compared to the other antipsychotics. And it also has shown some reduction in suicidality, where none of the other antipsychotics have shown that. Okay. So quickly looking at schizophrenia epidemiology, really it's pretty low. The global lifetime prevalence is about 1%. You see about 2.2 million people in the United States are diagnosed with schizophrenia. Most common onset you see is late adolescence to early adulthood, primarily, well, a little bit more common in men versus women. And then usually we see males present earlier on in age versus females is a little bit later on. You can see very early onset schizophrenia and late onset, so like in 45-year-old, but that's pretty rare. So looking at the symptoms of schizophrenia, really I think of it as 3 major clusters. You have your positive symptoms, so delusions, so fixed false beliefs generally outside of cultural or societal norms. You have hallucinations, which is a sensory perception with no basis of external stimulation. You can have disorganized speech, so that's frequent derailment or loose association, so constantly moving from one topic to the other, tangential, incoherent, and then repeating words. And then you can also see grossly disorganized or catatonic behavior, and this can range from stillness catatonia to purposeless movement, all the way to agitation. Then you have the negative symptoms of schizophrenia, which are blunted affect. You see a reduced intensity of affect, alogia, so inability to speak, so they may not speak to you, avolition, so lack of desire or motivation to pursue any sort of goals, anhedonia, inability to experience pleasurable emotions, and then amotivation, so the inability or unwillingness to participate in normal social situations. And then you have the cognitive symptoms, which are really kind of the effects of the positive and negative symptoms, I think. So you have impaired attention, these patients have trouble with working memory, they have trouble with verbal fluency, as well as difficulty executing tasks. So quickly, I just wanted to review the 4 major dopamine pathways in the brain that can explain some of the symptoms of schizophrenia, the therapeutic effects, and some of the side effects that we can see from our atypical antipsychotics. So first off, I'll start with the mesolimbic pathway. So this pathway is involved in usually pleasurable sensations, but when we see increased dopamine in this pathway, in the case of schizophrenia, we can actually see increased positive symptoms, so delusions, hallucinations. Then you have the mesocortical pathway, which actually in schizophrenia, you see a reduction in dopamine production. And this reduction can lead to some of those negative and cognitive symptoms. Then you have the two other pathways, nigrostriatal and tuberoinfundibular. And those two pathways really are responsible for some of the side effects that we can see from the antipsychotics. So in the nigrostriatal, it really controls motor function and movement. And when we block dopamine in this pathway from our antipsychotics, we can see extrapyramidal symptoms, which we'll talk about here in a sec. And then in the tuberoinfundibular pathway, this pathway controls prolactin secretion. And then when we block dopamine in this pathway, we can see elevations in prolactin. You can see sexual dysfunction, galactorrhea, so milk production, sometimes gynecomastia, as well as potentially some menstrual cycle changes. All right, so I figured I would go over kind of the basics of what makes atypical antipsychotics atypical. Why do we call them atypical versus just second generation antipsychotics? So there was a study done in 1990 that kind of looked at this, and primarily what it saw was the atypical antipsychotics have a much better side effect profile in regards to extrapyramidal symptoms and tardive dyskinesia. So just really quickly a review of extrapyramidal symptoms. I do this with my students because everyone gets EPS very confused, like what's involved in EPS, what are the different symptoms. The treatment is very different, which is a whole nother talk later on for the treatment of EPS and tardive dyskinesia. But so EPS consists of three basic symptoms. You have dystonic reactions, which are an involuntary tonic contraction of the skeletal muscle. Usually it's most common in oral and facial areas. It happens within the first 24 to 72 hours of starting or increasing an antipsychotic with a really potent D2 blockade. And it can be a medical emergency because their throat can close and they can stop breathing. Then we see pseudo-Parkinsonism or a Parkinsonian symptoms. So these are kind of generalized slowing voluntary movement, so bradykiniasias, achiniasias. Usually we noticed most often cogwheel rigidity in the arm or a resting tremor, pill rolling or shuffling gait. And then we have akathisia, which is this strong subjective feeling of distress or discomfort, inability to sit still or stand, and it occurs within the body. So a lot of patients will explain, like, my insides are crawling, I have to get up and move, I can't sit down. And the symptoms are only alleviated if they're constantly moving. And then you have tardive dyskinesia, which is very different than extrapyramidal symptoms. So tardive dyskinesia actually is this stereotypical involuntary movement of the mouth usually. So you can see like sucking or smacking of the lips, lateral jaw movements, tongue protrusion out of their mouth. You could see choreiform movements or purposeless quick movements of the extremities, trunk, and neck. These can be reversible if caught early, but usually we see these tardive dyskinesia symptoms in those that have been treated with typical antipsychotics for a long period of time. These symptoms present months to years after initiating antipsychotics and can be permanent if we don't do anything soon, once we realize they're having those symptoms. So basically, that's just a quick review of EPS and tardive dyskinesia, but basically, atypical antipsychotics have a very low risk of those two, depending on the antipsychotics. So we'll talk about that in a minute. Also, because of the mechanism, which we'll talk about, you potentially could see decreased negative symptoms or not a worsening of negative symptoms. You could sometimes see improved cognition, improved dysphoria. You see reductions in prolactin elevation. And then really, because of all these decreases in side effects, you usually see improved adherence to the medications. All right, so let's talk about the mechanism and how they differ between typical antipsychotics. So all antipsychotics reduce dopamine neurotransmission, and that's via dopamine or D2 antagonism. We also do have D2 partial agonism, which are the newer antipsychotics, aripiprazole, brexpiprazole, and cariprazine. I think of a D2 partial agonist as kind of, it's creating an equilibrium of dopamine where you're not getting too much and you're not getting not enough. So what kind of sets apart atypical antipsychotics is there's three different things primarily. You have a rapid dissociation from the D2 receptor. So the older antipsychotics would bind to the D2 receptor and stay. So if you think way back to your like chemistry undergrad class and you think of ionic versus covalent bonds, I think of an old antipsychotic as a covalent bond. It binds and it doesn't let go. So you get a lot more side effects like EPS, where the atypical antipsychotics have more of an ionic bond. So you see this rapid dissociation, they're on off. So they're really trying to create that equilibrium of dopamine. The other kind of special mechanism it has is all of the atypical antipsychotics have 5-HT2A antagonism. So what does that mean? Basically, the antagonism of 5-HT2A increases dopamine neurotransmission in the nigrostriatal pathway, which theoretically would reduce extrapyramidal symptoms. It also theoretically, this is where theoretically it would improve negative and cognitive symptoms of schizophrenia because it increases dopamine in the prefrontal cortex. The data really hasn't supported that, but theoretically it's a mechanism. And then some of the antipsychotics, atypical antipsychotics, have 5-HT1A agonist activity. And agonist activity at the serotonin receptor actually also would increase dopamine in the prefrontal cortex, which theoretically would help with negative and cognitive symptoms. That receptor also is thought to help with anxiety as well, because some of the atypical antipsychotics have anxiolytic properties. And then we have our other receptors that usually are really associated with the side effects. And so we have the muscarinic, the histamine, and the alpha-1 antagonism, which we'll talk about here in a sec. So I know this graph is really tiny, and I apologize, but I thought it was a really good one. And I put the reference down at the bottom for you. But basically what I wanted to show you here is that not every atypical antipsychotic is the same. They have very different binding affinities to all the receptors that we talked about, causing different effects and side effects. It's nice because basically at the bottom there, this graph shows the therapeutic effects of that receptor, as well as kind of the common side effects of that receptor, what you'll see. So this looks more, again, these graphs are kind of for your reference. I'm not going to go through all of this, but so depending on the receptor binding affinity of the different receptors, you can see different side effect profiles. And some of these side effect profiles can be beneficial. So like sedation, quetiapine causes a lot of sedation, but it might be a good option for someone who has schizophrenia or is in a manic episode of bipolar disorder that hasn't slept in a week, and we want them to sleep to calm down their mind. So Seroquel is a good option. Again, like I said, EPS and tardive dyskinesia are pretty low. The highest risk are paliperidone and risperidone. They actually have a more potent D2 binding affinity compared to all the other ones, and they're more like a typical antipsychotic. I have an asterisk by Abilify because some of the partial D2 agonists, like I had mentioned before, they actually cause their biggest side effect is akathisia, and the proposed mechanism is that partial D2 agonist activity. Acetylcholine, you'll see kind of a consistent trend. There's a few antipsychotics that have all of the side effects. So acetylcholine, some muscarinic side effects, you have clozapine, olanzapine, and you can see quetiapine. QT prolongation really, we'll talk about here in a little bit on how to manage that, but we really see the highest risk with quetiapine, but also ziprasidone is one of the worst offenders. Hyperprolactinemia, again, anything that binds strongly to the D2 receptor, so paliperidone, risperidone, we're going to see, and then we talked about sedation. More side effects for you to look at. Orthostasis or orthostatic hypotension. I think a lot of people forget about this one, especially I've noticed on kind of the inpatient unit. we're starting these meds, we're going fast up to try to stabilize them, and they can get orthostatic. And the risk obviously is falling. As the older you get, obviously you have more risk of fractures from falling, so something to take into consideration. The highest risk for sure is clozapine and then quetiapine thereafter. Weight gain, again, the worst offenders, kind of the same strain, clozapine, olanzapine, and quetiapine. So weight gain, glucose intolerance, and lipid abnormalities, really those are our triad of metabolic syndrome, which we'll talk about later. And again, those are the three worst offenders. Seizure threshold, really they're all pretty low risk except clozapine. That is one of the main side effects. And then you can see transient elevations in LFTs. Usually it's not concerning and most common with olanzapine and quetiapine. All right, so I kind of wanted to just quickly talk about how do you manage all of these side effects, because I imagine this is kind of what you're seeing in primary care is they're started on these antipsychotics either by the psychiatrist or yourself, and they're coming in and they're complaining of all of these side effects that they're experiencing. So really, obviously, our anticholinergic side effects, pretty obvious. So increase in exercise, fluid intake, and stool softeners if they're having constipation. If they're having dry mouth, you could do sugarless candy or gum. QTC prolongation, primarily it's avoid combinations of meds that prolong QT risk, and so, or increase QT risk. And so I think of fluoroquinolones, so antibiotics, Bactrim, ondansetron if you're giving it a lot, things like that, that maybe you don't necessarily think of that prolong QT, but if you're adding it on to an antipsychotic, it's definitely something to consider to monitor. Just a quick review on what is a prolonged QT and when do we have to be really concerned. Usually they say there's differences in the literature, but they say around anything above 450 for men and then 470 for women is considered a prolonged QT. Really, when I get a little antsy and start wanting to discontinue therapies is when the QT gets over 500 milliseconds, or if you have more than a 30 to 60 millisecond increase. At that point, your risk of torsades and cardiac arrest goes up significantly, and you really want to consider modifying therapy. Usually I try to modify the antibiotic if we can, or something that's more modifiable, but if it's really a risk, you might need to discontinue the antipsychotic. Or switch the antipsychotic. Prolactin elevation and sexual dysfunction. There are some techniques to help with this. You can switch to a prolactin-sparing antipsychotic, which basically is a partial D2 agonist, so Abilify, brexpiprazole, or cariprazine. There actually is some data to show that if you add low dose Abilify, so 1 milligram onto the antipsychotic, you can actually counteract that D2 blockade in the tuberoinfundibular pathway and help improve prolactin and some of the other side effects that go along with it. The problem is usually insurance companies are like, why are you prescribing 2 antipsychotics? And then they won't cover it. Most antipsychotics will increase prolactin, so if you draw it, it will be elevated. Really, the key is if they're having side effects from that elevated prolactin, then you should probably do something about it. Bromocriptine is a dopamine agonist that can be used. Again, you have to be really cautious though, because if they're on an antipsychotic because of psychotic symptoms, you want to be careful because you don't want to give too much dopamine because it can cause them to become psychotic. And then obviously if they're having any sort of sexual dysfunction, you can use their erectile dysfunction agents. Sedation. Pretty obvious, so trying to do bedtime dosing, decrease the dose or divide the dose, and then you could potentially switch to another antipsychotic with less sedation if it's bothersome. Same thing with orthostatic hypotension, slow postural changes, so really talking to the patient about not moving from a sitting to a standing position or vice versa quickly, trying to get up slowly in the morning and slowly rise out of bed. You could decrease dose or switch antipsychotics. So I think I really wanted to focus on the metabolic side effects, metabolic syndrome for this talk, considering everyone in primary care. I think this is an area that, and this is my personal experience, but also I think the data supports it, that I think this is kind of off of our radar a lot of times. And these side effects that the antipsychotics can cause can be really detrimental to patients. So some of the antipsychotics cause significant metabolic side effects. So you see some significant weight gain over time. You can actually see increase in glucose and dyslipidemia in the absence of weight gain as well, so making sure you're lab monitoring. The proposed mechanism of this is the antihistamine effects, the anti-muscarinic effects, so the M2 and M3 receptors actually modulate beta cells in the pancreas, and that causes changes in insulin and glucagon, which increase appetite and then increase glucose levels. And then the 5-HT2C blockade, which some of the antipsychotics possess. I don't know if anyone of you have heard of the newer medication Belviq or Locaceren. It's a 5-HT C agonist, which actually reduces appetite. So obviously, if you block that receptor, you could potentially increase appetite, increasing weight gain, hypertension, diabetes, high cholesterol, things like that. Really, the treatment, obviously, lifestyle modifications, trying to get them to exercise and eat right. Medications can be used. There's actually data to support metformin and topiramate. Most of the data is in child and adolescent population, and the adult data really has shown it prevents weight gain versus causing weight loss. And then you can consider switching the antipsychotic, but this is kind of questionable because if they're stable in their psychiatric illness and they're, doing well in life, you want to weigh the risks versus benefits of just automatically switching an antipsychotic that they're doing well on. So I think this is the area for improvement. I know I'm working here at the hospital to develop some sort of monitoring system to try to have a better monitoring system for metabolic syndrome. So back in 2004, I know this is old, but not a lot has changed. There was a consensus from these organizations to develop monitoring parameters for metabolic syndrome. So basically, they recommend baseline, before you even start the antipsychotic, looking at a personal and family history of metabolic syndrome, looking at weight gain, so BMI, waist circumference, blood pressure, fasting glucose, and then fasting lipid panel. And then thereafter, basically, you repeat some of the labs at 12 weeks and then annually thereafter. And really, you're looking at change over time, to see if these patients are developing some of these symptoms and then appropriately treating. So I had to get my little pearl in here, quetiapine for insomnia. So I don't know how the two psychiatrists sitting next to me feel about this, but I'll let them weigh in after we're done with the presentation. So quetiapine for insomnia. It's obviously used often, I think, in psychiatry as well as primary care. I see it. It's off-label. The reason why, and I'll show you a graph in a moment, is that low-dose quetiapine at doses of 25 to 100 milligrams primarily is a histamine 1 antagonist, and that causes a lot of sedation, which is good for a lot of people. But the data surrounding the use is limited. I actually, and the trials basically comparing quetiapine to other active controls like, say, zolpidem are non-existent. So I actually saw this review out of the VA that came through on my listserv, so I was really excited because this is the first trial that I know about. It was a retrospective trial that looked at low-dose Seroquel and the effects on metabolic syndrome. So what they found was, it was a retrospective chart review of 403 VA patients. The average dose of Seroquel was around 116 milligrams, and the average duration was about 44 months, so quite a long period of time. And what they found was increases in systolic blood pressure, diastolic blood pressure, BMI, weight gain, as well as fasting blood glucose, all statistically significant. Interestingly enough, they saw a decrease in total cholesterol. I don't know where that's coming from, but but as you can see, even the low-dose Seroquel can still cause risk of metabolic syndrome. obviously increasing the risk for cardiovascular disease, early death, things like that. So really weighing the benefits versus the risk. You know, if someone's on Seroquel for, you know, stabilization and we're using it at bedtime, that's fine. Or if they're on the inpatient unit and they acutely need to sleep, that's probably okay. But if someone is antipsychotic naive, they have no other antipsychotics on, and you put them on Seroquel, it's probably not the best agent. So here's the graph I was talking to you about. So if you look going up the estimated receptor binding affinity occupancy, and then over time. So this is looking at quetiapine immediate release 50 milligrams. And what we see, just like I said earlier, is at low dose, the primary receptor that's being affected is histamine, which is why it's so sedating. All right, so this wouldn't be a pharmacist talk without drug-drug interactions. It's something I do on a daily basis because unfortunately in psychiatry we do have a lot of drug-drug interactions. Why do we care about this? Some of the interactions can be significant where it reduces effectiveness, or we have increased risk of side effects or extrapyramidal symptoms. I don't expect you to memorize this table at all. I just want everyone to know the importance of doing a drug-drug interaction check and then making sure we modify doses as appropriate. So primarily, the big enzymes in psychiatry that we worry about are the 1A2, 3A4, and 2D6. What I wanted to point out, I don't know how many people are, you know, dealing with clozapine out in primary care, but I think the biggest risk for clozapine is 1A2 inducers. So the biggest 1A2 inducer that I think about is smoking. So actually the hydrocarbons or hydrofluorocarbons in tobacco smoke actually is a really potent 1A2 inducer. So what we see with clozapine patients is they go out into the community and they're smoking and their clozapine level is induced. They have lower levels, so the dose is increased, you know, over time. And then we admit them to the hospital and we continue them on that really high dose of clozapine, you know, clozapine 700-800 milligrams a day, and they can become toxic, which is very significant. But also on the flip side, if we start someone on clozapine inpatient or we increase the dose to an appropriate level, and they go out in the community and they start smoking, they induce all their clozapine away and they destabilize and are admitted back into the hospital. So I think it's a big interaction to be concerned about. And then the other one I really wanted to point out was lurasidone. So it has a contraindication basically with use in 3A4 inhibitors and inducers. The primary one that I normally see is actually lurasidone with carbamazepine, which is a very strong inducer of 3A4. Carbamazepine induces lurasidone concentrations down to basically nothing. So you're taking a placebo. So it's a very important drug interaction. So moral of the story is do your drug-drug interaction checks. All right, so I wanted to really quickly touch base on tapering and switching antipsychotics because I know that was a request a while back. So there's really no specific guidelines that exist for tapering or switching antipsychotics, as well as the duration of the taper. And there's really limited data to support any of the approaches that we do. But I think that there's three kind of main options that we have for switching in between antipsychotics. So one is abruptly discontinuing the medication and starting the other medication. So this might be a good option for probably the inpatient unit just to monitor for any withdrawal symptoms because of the receptor affinity differences between the antipsychotics. And it's really not recommended for clozapine discontinuation. Usually you need an extensive titration schedule, and that's probably when you want to consult psychiatry before you manage to do that. You can start the new medication at full dose and then actually slowly taper the existing medication. It's really dependent on patient tolerability and slowly tapering the existing medication. And then you can see cross titration, so slowly tapering the existing medication and then slowly increasing the new medication up. Tapering schedules can be relatively quickly inpatient, so 3 to 7 days, And outpatient, usually I recommend 1 to 3 weeks or more because you're not seeing them every single day. You're seeing them, you know, every couple of weeks to maybe every couple of months. Tapering antipsychotics, really, you want to take into account the half-life, any patient-specific factors, but the general approach really is about a 25% reduction weekly. You can go slower if warranted, depending on how the patient is doing. And then really monitoring for those discontinuation symptoms, rebound, or agitation. So this is kind of a really neat website. I just heard about it from one of my colleagues, and they swear by it. I took a look. It's called SwitchRx. It's a free login, and it primarily focuses on antipsychotics and antidepressants. But it has a lot of cool information about taper, titration schedules, clinical tips, drug pharmacokinetics, pharmacodynamics, and other precautions that you have to worry about. But you literally just put in the 2 antipsychotics or the 2 antidepressants that you want to switch from, and it'll give you based on the drug information, it will give you kind of a schedule of how you switch between the 2. Cool. Yeah. I haven't used it clinically, but I'm going to hopefully try one day to see if it's accurate. And then finishing up, I just wanted to give some administration pearls. I see this often with patients where they're either on lorazepam or ziprasidone and they want to take it at bedtime because it's easier, or maybe it causes a little bit of sedation. But the problem with these 2 medications is they really need at least lorazepam 350 calories and ziprasidone 500 calories for adequate absorption. So the studies have shown that concentrations of these medications can be reduced pretty significantly, around 80%. So again, you're getting more of a placebo effect if you're not taking it with food. Very, very important. Usually I say the biggest meal of the day, most often that's dinner for most people. And it's without regard to any sort of fatty meal. It just seems to be calories. Acenapine or Saffris is really interesting. It's our only sublingual tablet. They recommend no eating or drinking for 10 minutes after because you want to get that absorption. But just at baseline, acenapine bioavailability when you take it correctly is about 37%. So it's very low absorption rate. So if you swallow acenapine or if you drink or eat afterwards and don't allow the medication to absorb, it basically reduces bioavailability to about 2%. So it's an inactive medication at that point. So, all right. That's all I have for you guys.